Dear ladies and gentlemen, dear friends and colleagues, it's my great pleasure to mostly welcome you to this workshop on the issue of the need to address sepsis on a national and a global level, given that sepsis accounts for more than 20% of all annual global deaths. I'm very pleased that the number of colleagues and interests in the room and hopefully also online, I welcome also all of you online, is really important. It expresses that we have 5 times more participants as we had on the last summit. So we are making progress, but it's not yet enough, as I said. And we have a great panel which will make clear also in terms of facts and not fake news how important it is. And we will not only speak on the burden, but also that what Dr. Tedros and others have said, that most of the sepsis deaths are preventable. And this is what it's all about and what we need to discuss to bring sepsis on equal footing with other major health threats. And our first speaker to address this is Professor Moshen from the Institute of Healthcare Metrics and Evaluation in Seattle. And he has addressed and will let us know on his research, which both has been published in The Lancet. Moshen, please.
Thank you. Good afternoon, everybody. I will try very fast because I have to cover many things. First, every year, same as 2019, we had 56 million deaths. From these 56 million deaths, we published this. This is not fake news. We published in The Lancet, and this, everybody knows about the result. From these 56 million deaths, 13.7 million deaths happened with sepsis, 18 million deaths due to the CVD, cardiovascular, and 10 million due to the cancer. And from these 13 million deaths, 13.7 million deaths due to the with sepsis, 8.8 million deaths was due to the bacterial infectious disease. And from these 8.8 million, 4.9 million, it means that 5 million was due to with resistance against antibiotic. Okay, then if we look here to this presentation, we had 2 words, with and due. Then let me go to the next one. Okay, everybody die one time with one cause. Okay, and these causes have to be underlying cause. What is the underlying cause? Underlying cause is the cause that start trigger chain of the reaction to the deaths. Then there are many causes that after underlying cause that start. Sepsis is one of them. Then sepsis is not underlying cause. But in the 13 million deaths, sepsis was intermediate cause. Same as pulmonary embolism, same as heart failure, same as peritonitis. But because all of the country published just underlying cause, usually we forget sepsis. Sepsis is 14 million deaths every year. How we calculated this? Okay, I don't go through that, but very fast, we gathered more than 150 million record of deaths, multiple causes of deaths, and we calculated fraction of the sepsis in the chain of deaths, and we run a model for this fraction and multiply this fraction on the result of the causes of death. Then we calculated number of sepsis for each 6-year age location. Okay, detail we published. I will show where we published. Okay. When we got this number, you will see here that biggest number, as usual, happened in the poor country. In the sub-Saharan Africa, we had biggest number of the deaths, that is 3.9 million. And then in the South Asia means India, Pakistan, Bangladesh, 3.8 million. And when you go to the high income, fraction of the deaths with sepsis, with the infectious disease decreasing, and with the non-communicable disease increase. Sepsis and non-communicable disease, yes. The biggest event in the non-communicable disease is the patient that goes to the hospital with the stroke, with the myocardial infection, with the injury, move to the one infectious syndrome to the sepsis and die by the sepsis. Okay, and again, here you can see that biggest number of the sepsis happen in the country with the low SDI, socio-demographic index. That explanation are here. But sepsis in the high income is very small compared with the low income. And you can see this is fraction of the sepsis by the country, estimated for 2019. The biggest number is in the LMIC country, and lowest number is in the high income country. And you can see we decreased maybe number of the sepsis, but we increased number of sepsis due to the non-communicable disease. We decreased number of sepsis because we decreased the infectious disease for the vaccination, for the many things decreased. But number of the sepsis in the non-communicable disease is not only stable, is increasing. You can see 5 million compared with the 3.9 million. Okay, you can see age pattern of sepsis. The biggest part of the sepsis is in the very young age and very old age. 3.3 million deaths in the under 5 happened with sepsis. We decrease, but if you look to the age between 30 and 50 and age 70 plus, number of sepsis is increasing by the time because non-communicable disease is increasing, and we do not control, we do not prevent deaths due to with sepsis in the non-communicable disease. Okay, let me just add one point that between underlying cause and sepsis, usually there is one bridge, that this bridge infectious syndrome. For example, some person goes to the hospital with a stroke. We use catheter for this person. This catheter make UTI, and then this UTI make an sepsis, and these people die. A stroke was not, was the underlying cause, was the process that started this chain. But one thing that we made, kill the person. And then there is between underlying cause and sepsis, there is around 11 infectious syndrome. That highest one is lower respiratory infectious, and then BSI, bloodstream infectious. We create, or we cannot control of the creation of this infectious syndrome. Then based on that, we push this person to the dying by sepsis. This is the last one. Okay, as you see, there are a lots of example. Here we have a stroke, that stroke has 6 million deaths per year. From these 6 million deaths, 9% die with the sepsis, with the which causes with the bloodstream infections, with the hospital source LRI, and same as this, we have 1.4 million deaths due to the cirrhosis, that biggest part die due to the peritonitis, and same as this for the COPD. Okay, we published our method in 2017 in the Lancet. We published synergies between sepsis and antimicrobial resistance in Lancet in January 2022. And we estimate and publish sepsis number in 2022, that it will happen in 2023, that is combination of the sepsis and COVID. Because everything that here I explained, it was before COVID. With the number of the COVID, all will add to the sepsis.
Thank you very much. We've got time for one question. There's indeed has been raised one question, is how COVID added to the burden of sepsis. There are estimates around that it's much more than this 6.5 million deaths from COVID, which are really documented. There are estimates that it's more than 20 million COVID deaths. What is your opinion on these estimates?
Exactly, that is a very important question, because every death due to the COVID is with sepsis, because based on the definition, we have two types of sepsis, explicit and implicit sepsis. Implicit sepsis is the infectious disease with the one organ failure causes. Then anybody that die with the COVID automatically die with the sepsis. Then all of the number of the COVID will add to the number of the sepsis. This is my point.
Thank you very much. It's my great pleasure now to announce and to have to tell you that we had to change again to a sepsis emergency due to Ebola in Uganda. That's the reason why our good colleague and friend Shevin Jacob could not make it in person here, but Emmanuel Nestebu, who is also an infectious disease specialist and the chair of the African Sepsis Alliance, was so kind to address the issue sepsis in sub-Saharan Africa, where we are very pleased that we very likely will have a big study in the next 5 years to address this issue, but you will hear more about this later. Emmanuel, please.
Thank you, Conrad, for that kind introduction, and thank you for inviting me to speak at this really important event. I'm going to be talking about addressing sepsis in sub-Saharan Africa. As Conrad said, I'm chair of the African Sepsis Alliance, a consultant infectious disease physician based in Abu Dhabi, Sheikh Shagbud Medical City at the moment. So this is probably my most important slide, and the key message for this presentation is really why we should focus on Africa. And Dr. Nagavi already brought this up. We've got an issue where we've got the highest burden of disease for sepsis in the African continent, but the least amount of sepsis improvement activities worldwide. And so we've got to really overturn this inequity, because everybody in Africa also deserves a chance to survive sepsis. So zooming into the burden of disease of sepsis in Africa, the 2017 Lancet Burden of Disease report estimated that there was 17 million cases of sepsis in Africa a year, which is 35% of the global cases. And in terms of deaths, 3.5 million deaths, which is 32% of global deaths due to sepsis. So a third of cases of sepsis and a third of deaths approximately are from the African continent, by far the continent most affected by sepsis. And if you want to put it in a different way, every minute, 30 people die as develop sepsis and 6 people die as a result of sepsis in Africa. And the issue with the African continent is it has the youngest population in the world, with 60% of the population being under the age of 25. So it affects younger people in Africa and disproportionate number of years of life lost. And so this, just to illustrate the point more, this is the also 2017 Lancet Burden of Disease report, showing the age standardized sepsis incidence per 100,000 population for both sexes. And what you see here is the African continent with the highest burden of disease for sepsis, with incidence of sepsis of at least 1,600 per 100,000 population in many countries in Africa, dark blue areas in Africa. And if you look at deaths and incidence, you will also see a similar picture, very high incidence of sepsis-related mortality in Africa, with countries in Africa also highlighted there in bright red, having an incidence of greater than 500 deaths per 100,000 population, so highest burden of disease. And one other way of looking at it is looking at mortality if you develop sepsis and you're admitted to a hospital in Africa. And this is a systematic review and meta-analysis of a few studies in Africa that have looked at mortality of patients admitted to hospital with sepsis in Africa. And you find a mortality of around 50%. So 50% chance of passing away if you're admitted to a hospital with sepsis in Africa, really high and alarming. Dr. Nagabi also raised the issue of maternal and neonatal sepsis. In Africa, sepsis tends to affect the younger population, and these are estimates of number of deaths related to maternal sepsis and neonatal sepsis. 130,000 maternal deaths globally as a result of maternal sepsis, and 300,000 neonatal deaths due to neonatal sepsis. And by far, more than 90%, close to 99% of maternal deaths occur in low and middle income countries due to sepsis. So it's really an issue of low and middle income countries and countries in Africa. So sepsis is the third most common direct cause of maternal mortality, and it accounts for around 11% of maternal deaths, significant cause of maternal and neonatal sepsis. But what is different about sepsis in Africa? And there's a lot of differences, but in addition to the younger population in Africa and disproportionate years lost, there's also different risk factors, higher HIV prevalence, malnutrition, and so mortality is also higher and complications higher because the population also has different risk factors, as opposed to Europe and North America, for example, where it tends to affect more the elderly with other comorbidity. There's also a difference in the type of infections that cause sepsis in Africa, and studies that have reported high rates of TB causing sepsis. In some studies, around 30% of sepsis caused by TB in high HIV prevalent areas. Zoonosis, that infections that are transmitted from animals to man, such as brucellosis, rickettsia infections, and also very high rates of antimicrobial resistance in low and middle income countries and Africa, and the African continent inclusive. There's also issues with limited resources and weaker health systems and lack of access to critical care services. So really need to focus on preventing sepsis and identifying sepsis early to prevent patients getting to intensive care, because mortality is extremely high. They don't have access to critical care. The health-seeking behaviors are also different. People tend to present late for a number of reasons, including transportation, for example, and the problem for transportation to healthcare facilities. There are some interventions also that cause harm. So we know from a number of studies in Africa, in adults as well as in children, the number of trials, for example, the FEAST trial in children and other trials I've done in adults in Uganda, showing that high bolus aggressive intravenous fluid resuscitation causes harm in patients with sepsis in Africa. So in summary, we've got a situation where we've got a continent with high burden of disease, more complications, high rates of complications, but very little data from Africa, and that's what we need to overturn. So what are the benefits of improving sepsis and recognition and management in Africa? In general, all this is underpinned by the United Nations Sustainable Development Goal 3, good health and well-being. A system that is able to recognize and treat patients with sepsis is more likely to be, is a system that's most likely to respond to critically ill patients in general, improve the care of patients with critical illness. It's most likely also to address antimicrobial resistance and stewardship, improve identification of control of emerging infections. And if you remember the outbreak we have now in Uganda, a strong healthcare system that can deal with sepsis can also identify and respond to emerging infections. Also, part of sepsis care is prevention and strengthening infection prevention and control. So that is also addressed by improving sepsis care. It also makes a safer health system and a more reliable and responsive health system. And all the outcomes in terms of improving reputation of a healthcare system or hospital, staff satisfaction, and reducing mortality, and also overall costs or benefits of improving sepsis care. So the African Sepsis Alliance is an organization that involves more than 15 countries and over 300 healthcare professionals working together with a mission to provide leadership to reduce mortality and suffering for sepsis in Africa. Everybody in Africa deserves the right to also survive sepsis. And so what we do is focus on education, one of the big shields that we work on. And this is an example of the International Sepsis Forum we hosted last year in Rwanda with the Rwandan Emergency Care Association, providing high quality education for healthcare workers across Africa. And we also focus on undergraduate as well as postgraduate education. In terms of research, Dr. Conrad already mentioned the proposal which is being worked on at the moment, which I'm sure he'll talk about more. But the African Research Collaboration on Sepsis is one of the examples of research driving improvements in sepsis care in Africa. And it's funded by the National Institute for Health Research in the UK and led by the Liverpool School of Tropical Medicine, and focusing on targeting non-adult, non-pregnant adults with sepsis, and answering some important questions such as short incident study on sepsis in Africa to describe the burden of disease of sepsis, and also identifying indicators for improving sepsis care in Africa. So sepsis being improvement being driven by research. Advocacy is crucial, and we've done that through a number of different means. One is the Kampala Declaration we published in 2017, highlighting the issue of sepsis in Africa, why it's important and how we think it needs to be tackled. We've published a number of published policy papers with the African Institute for Policy Development, AFIDEP, and those are all available by our website. And then we've also produced a video for members of the public explaining what sepsis is, what the risk factors is, what the symptoms are, and also how to prevent sepsis and how to present what to do if you feel you've got sepsis. But one area where we need to work more on is involving crucial organizations in Africa, such as the CDC Africa, African Union, and WHO Afro. And we're making strides, but not as fast as we would like to. And we really need these organizations to engage more with sepsis improvement. We also need countries in Africa to identify countries that can demonstrate sepsis improvement at country level. We've had that in Europe, we've had it in North America, we have that in Australia, but we have not yet had that in Africa. So we need countries also that get involved and can show what can be done in terms of sepsis improvement and saving lives. We need large-scale improvements in clinical services, which we haven't had so far in Africa, to have an impact on sepsis improvement, with sepsis performance projects, which have been demonstrated in the West, audit and quality improvement, focusing on recognition, management, but also coding and surveillance. Dr. Nagavi also would have mentioned that a lot of the data estimating sepsis burden of disease in Africa is actually from other continents, not from Africa. And we need data from Africa, and that's something we need to cure. Sepsis is complex with multi-different facets, and we need national action plans for sepsis in African countries. We've also got that in other countries, in Europe, in the UK, Australia, but we haven't got a country in Africa with a national action plan. And we need to develop that and roll it out to countries in Africa to have the impact which we know it should have. But most importantly, we've also got to involve patients and members of the public. And we've done that through the public awareness video. But as you would imagine, it's not easy explaining to somebody in Africa what sepsis is. And we haven't yet determined the level of awareness about sepsis in Africa. In other continents, it is quite low. In Africa, it's likely to be extremely low. And so we've really got to involve members of the public and patients so that they understand what sepsis is and also advocate for the change which we need for sepsis improvement. And I'd like to stop there and thank you. And I look forward to taking questions.
Thank you, Emmanuel, for this great talk. I hope you can stay with us for the final discussion because for the sake of time, we have to continue now. And it's my great pleasure to introduce Jeanette Diaz, who has been from the very beginning with us, including the fact that she as an intensivist trained in US, but also having worked for WHO also in the times 2015 and 16 when we aimed for a sepsis resolution as at WHO. Jeanette was very instrumental and helpful to get this done, and now she is responsible with a full job at WHO for emergencies, and she knows quite well what she is talking about.
Thank you, Conrad, and it's my privilege to be here with you all today. So as discussed, I'm Janet Diaz. I lead the clinical unit in the health emergencies program, so the one that's responsible for responding. And a lot of the meetings, many sessions have been around pandemic preparedness and response. And so that keeps me busy, as everyone has been busy throughout this pandemic. I think it should be clear at this point that sepsis is the common pathway through which infectious diseases cause severe disease and death. And I'm not going to, I think that was said clearly by my colleagues. So that's not that we understand that. But it depends on the pathogen and it depends on the person, what that clinical presentation will be like. And so COVID-19 pandemic really opened our eyes to sepsis in the sense, right? We started to see patients with acute respiratory distress. And and then that's when we started putting COVID-19, SARS-CoV-2 infection at the top of the differential diagnosis. But we've been seeing pneumonia for a long time. We've been taking care of patients with pneumonia, from pneumococcal pneumonia for other causes of pneumonia. Pneumonia prior to COVID was one of the, I don't know the number, but a leading cause of death in children less than 5. So we have been battling with sepsis from many different infectious diseases, as was already shown, and COVID-19 just adds the numbers to that. And currently, as has already been noted, my colleagues in Uganda, seeing other patients, they're not seeing patients now with acute respiratory distress, but they're seeing patients with severe diarrhea, dehydration, bleeding, shock due to Ebola virus, Sudan virus. So again, the common pathway to death and severe disease being sepsis for Ebola virus disease. So despite of these different presentations, which does add complexities to the clinical, recognition of cases, it is important to understand that the common pathway being acute organ dysfunction, and that's one of the fancy ways we say about patients who have sepsis who have respiratory, neurological, kidney, liver problems. But this needs to be assessed immediately and recognized immediately and treated immediately in order to save lives. And that's what we've done. That's what we tried to do with COVID-19. So I think it's important then to use the lessons, the investments from COVID-19 pandemic and the implementation of the COVID-19 clinical care pathways that were developed and implemented all around the world to take care of patients with COVID-19 in the community and in the health systems, and to strengthen those clinical pathways and expand them to sepsis care pathways from the other infectious hazards that were preceding COVID-19, and then potentially other emerging infectious diseases that we may see. So there's 5 key elements that I want to share with you. The first is know your hazard. What are the infectious hazards or the infectious diseases your communities are at risk for? That will depend potentially on the age, as we saw younger people, older people. It may depend on where you live. If you're in parts of Central West Africa, where there is Ebola virus, it may depend if you just had a surgery. So know your infectious hazards, because those are the hazards you have to prepare for with your clinical care pathways. The second is prevention. Prevention is key. Everyone's been talking about prevention, and it's best to prevent. It's easier to prevent, and you will save many more lives that way. So what are our options here? What we've learned, obviously, in COVID-19, we were able to find effective vaccines, but we have vaccine preventable diseases, and making sure people's vaccinations are up to date is really important. Infection prevention and control in healthcare facilities to reduce, nosocomial infections, to reduce the spread of communicable diseases within the hospital. And then for certain pathogens, we do have public health interventions. For example, for Ebola virus disease, what's the main public health intervention going on now is contact tracing and following people through that period after exposure and making sure that they're recognized as soon as they may develop a symptom and tested and treated. So after prevention, the second theme is early recognition. And I put early recognition and diagnostics. So people, frontline workers, so again, this is really in the community, and there was a great presentation before by some colleagues talking about how important it is that the warning signs are detected within the community. These are the people that we're trying to save lives. So healthcare workers need to increase their competencies in detection, diagnosis. If someone has a suspected infection, that they look for the signs of sepsis to see if that patient may have severe infection. And this can be done with standardized tools for screening and triage, as have been done for COVID, and also have access to diagnostics that are reliable and accurate. The third element is treatment. Patients need to be treated. As discussed, sepsis is an emergency, and so the sooner you can start the right treatments, the better. You can save lives. So for treatments, we have I put two buckets here. One is supportive care treatments. So that would include simple interventions such as oxygen therapy, which I'll talk about in a little bit. Fluid therapy, but give the right amount of fluid, as Emmanuel talked about. And then disease-specific therapeutics, such as antivirals or antibiotics. And then the bucket of immunomodulators, which I think someone will discuss after me. So in COVID-19, we did see an incredible acceleration of research and development and evidence generation and synthesis to make recommendations for how we can treat SARS-CoV-2 virus. And we made great advancements. And based on that, WHO, of which this is part of the technical work that I lead, writes living guidelines. So what drugs should we be using for COVID-19? And so right now we have recommendations for 3 antivirals. You can choose one for patients who are at high risk for severe COVID, for severe manifestations of COVID-19, and give them one of those to reduce their risk of hospitalization. So that's targeted testing and treating for patients at risk for severe disease. And for those that are severe and critical, that are already in a status where they're likely to be hospitalized and have 1 or 2 multiple organ failure, then those patients get immunomodulators. And there's robust evidence that was generated during this pandemic to find the life-saving benefits of corticosteroids, IL-6 receptor blockers, and Janus kinase inhibitors, or baricitinib. So we have treatment options. So the important here then is make sure the patient can get them. So one of the biggest lessons learned in COVID-19 as well was not just the evidence generation, since there's a recommendation, we can say this will, we think this is will save your life or will reduce your risk of hospitalization, but we also needed access to life-saving interventions. So during the pandemic, the ACT-A partnerships, of which many important, multiple stakeholders and community representatives got together to see how can we make access to life-saving therapeutics, life-saving vaccines, diagnostics. And I'm going to put oxygen here. I want to highlight really what we learned about oxygen during the COVID-19 pandemic. And we also know oxygen was the first life-saving medicine for COVID-19, for severe COVID, right? That's all we had at the beginning. But we also know that there was limitations in the availability and correct use of oxygen in many parts of the world. So again, the same ACT partnership, which made an O2 task force, which has been my pleasure and privilege to be a partner and part of, has invested millions of dollars, big investments in oxygen, setting up oxygen at the subnational and national level in many low middle income countries. This includes big oxygen generation plants that you can put on site. It includes access to liquid oxygen. And that has been a major intervention that I hope now, not only is it for COVID-19, but it's for patients who have sepsis due to other infections, as well as to patients who require oxygen because of another critical illness, such as trauma. So before I move on from oxygen, another big important interventions that were studied during this pandemic, which do apply to other infections, would also be the use of non-invasive respiratory support devices. So we improved our understanding a little bit of how to best manage patients with respiratory failure, acute respiratory failure. So finally, before I sum up, the fifth point is about actually survivorship or after the acute illness. Again, from COVID-19, we also saw, and we know now, big numbers, also estimates coming out of IHME on post-COVID-19 condition, right? Long COVID, as many of you know it by. So after the acute illness, what are the longer term effects, symptoms that can be devastating for some and require coordinated multidisciplinary care and access to care? So in summary, from COVID-19, we know severe manifestations of COVID-19 are sepsis, the mechanisms, the death, the burden of disease that we don't have the exact numbers for because those are still being worked out by our colleagues, but they will be huge. We also know the burden of disease of post-COVID-19 condition is huge. But we need to take this opportunity to learn what we did do and all the investments we made for COVID-19 in the community and in the health systems and get them integrated. So it's not just a COVID-19 care pathway. It's a sepsis care pathway. It's the infectious hazards, infectious diseases, clinical care pathways that go through the beginning from prevention to early recognition, diagnostics, right treatments for the right patient at the right time, and then post-acute illness follow-up and recovery. So we have to seize the moment and use what we've learned to be ready for another emerging infectious disease, but take care of all the diseases before COVID-19 that we already knew about. So thank you.
Yes, Jeanette, thank you for this excellent talk. And I propose that we really jointly discuss this after we have heard the next speakers. And you have alluded to already to the fact there are new options also in terms of immunomodulation. And it's my great pleasure to introduce Niels Rüdemann, who for 10 years almost ran my ICU in Jena. And at the same time, he also had done research and finally founded a company called Inflarex. And he will report, given his both great track record in research, clinical care, and development of novel therapeutic agents for sepsis or COVID. Niels, please.
Yes, thank you so much, Konrad. My pleasure. Thanks also for inviting me today, and thanks for the great introduction. I'm going to share my screen, hoping that this will work out fine. So I was asked to talk about immunomodulation in COVID-19 and why this and how this may save lives. And as Konrad said, I'm an intensivist by training. I'm also an immunologist by work in laboratories and as a researcher for many years. And I founded a company together with my colleague Renfeng Gur, goes back to University of Michigan research on sepsis. And more specifically on the innate immune response, on our host response, and the most, I would say, the fastest and strongest and oldest system we have, the complement system. So I want to start with why target the immune response in critically ill COVID-19 patients. So there is great advances in development of vaccines and targeted viral therapeutics, but there are still patients progressing to critical disease and viral sepsis, and these patients remain at high risk of death. And there was just a recent publication showing that vaccinated and non-vaccinated patients had still, death rates of over 60%, others speak of 50%. So why else? Like targeting the immune response in viral sepsis is considered a virus independent mechanism. And that's very important because that may serve as something that is readily available during a pandemic preparedness situation where you don't have yet the time to develop targeted therapeutics or vaccines. So you may bridge this by having something that can probably reduce the death toll. So when you look at COVID-19, and this has been shown probably in different ways, we developed this within the beat cough initiative in Germany. And obviously there are different areas and different situations in which a COVID patient can get. And apologies that I just see that the upper headings here are still in German. But during the first stadium, you have the viral infection, and sometimes patients are asymptomatic and they can still and already infect people. But as you move into a stadium 2, where you may have symptoms, which most patients will have, you're getting less and less infective over time. And as you develop oxygen need and may go to the stadium 3, viral sepsis and organ dysfunction, oftentimes viruses cannot be isolated anymore, but it is common knowledge that these patients suffer from a very strong host response and are in severe inflammation, and that may cause death. And then we're all aware that there's a long-term sequelae if you survive this, but there's also long COVID here when people recover that may have not gone through the very severe setting. So what can be done to work on these patients specifically, which is of course the smallest group of patients that gets into the stadium 3. However, there is a very high unmet need because these patients are dying. Now, this is like old research really in sepsis that goes to the concept of how immunomodulation works. And as you can see, there's two paths. There's the innate response, the inborn, usually system-based response, which is very fast, hours to days. And that usually involves first the complement system, which gets activated, which in SARS-CoV-2 is certainly the case. And as key mediator of the complement system is a small called anaphylatoxin, C5a. The word toxin already says it. It can kill you. It can kill mice if you activate it strongly. But then also the broader response involving cytokines, receptors, neutrophils, and all the mechanisms that come with it. And then, of course, when that kicks in, you have the symptoms, the classical symptoms, and the consequences going into tissue damage and organ failure. Now, the idea was recognizing, this was going back to over 100 years, recognizing that it's the body response from which the patient appears to be dying rather than the bacteria, for example, itself. The idea was to intervene, intercept, so that you can prevent or limit the tissue damage and organ injury. Now, on the other hand, you have the adaptive host response, which is the antigen processing T cell and B cell response leading to antibody generation, but that takes several weeks. And of course, here is the entire work of vaccines trying to get there fast and get you protected. Now, I want to focus a bit on C5a because this is really the research that we've been involved in here, as I mentioned, and this is a very robust, very early system of our host response. Now, when you look at the complement pathways, this is 50-year-old knowledge. There are three pathways. The mannose binding lectin here in the middle is exceptionally strongly activated by SARS-CoV-2. So this is like the coagulation system. It's proteins in the blood that get activated in a cascade manner. And in the end, C5 gets cleaved. There's an important defense mechanism, the membrane attack complex here on the right side, and C5a on the left side. Now, even though this is common knowledge, it's not really in the minds of people that this is happening in viral sepsis that is extremely severe when it comes to the consequences. And you see here on the left side, COVID patients have absolutely activated C5a levels. And in fact, it was also shown that they correlate with disease severity. And that was actually studies very early in the pandemic. Now, there's also a direct way, enzymes, and for example, coagulation pathways can also activate C5a. So this is activated, and this is in and of itself the proof that in COVID, when you get to critical illness, the innate host response is strongly activated, these levels of C5a. Okay, so I want to share with you some data that we generated in a phase 2 and a phase 3 study here in critically ill, invasively ventilated COVID patients. We started out early in the pandemic with a small 30-patient trial, randomized but open label. And it was a very interesting concept, even though we had a good idea about the dosing. but we wanted to understand the patients. And so we had an expert committee that looked at the patients every week. And really trying to understand, how do the patients look like? How does disease develop in these critical patients? What are the endpoints behaving like that we're looking at? And we learned that apparently our intervention with the C5a inhibition seemed to have a trend to less mortality, which you see on the right side, a hazard ratio of 0.65. And we also saw fewer patients with renal impairment and some biomarkers that were comforting. And in general, we learned that the oxygenation index, which was described as one parameter early in the pandemic, seemed to be very variable. Patient positioning, maneuvers had a big impact. So this seemed to be not suitable as response parameter. So based on this, and this is published in the Lancet Rheumatology, we developed this hypothesis, which is also based on 15 years preceding research on the role in sepsis. So this is a blood vessel, and the idea is complement is activated through SARS-CoV-2 and C5a is generated and it activates neutrophils. This is the key mechanism that leads to tissue damage because neutrophils can produce oxidative radicals and enzymes and netosis. And that leads to vascular damage, really, and it strongly kicks on the coagulation system. So what you get is microangiopathy and thrombosis moving then into organ dysfunction. And this is exactly what we see in COVID. So in a way, COVID assembled probably the most clear signs of viral sepsis that we've ever researched in. So this prompted us to do a phase 3 study, and just a couple of slides here. This was a rather large phase 3 study. To our knowledge, it's the largest global study conducted in invasively ventilated patients, which was double-blind and placebo-controlled and really powered to show a mortality difference. And 28-day all-cause mortality was the primary endpoint, alongside with the key secondary 60-day. And then we also looked at ordinal scale kidney dysfunction, renal replacement need, and of course, safety. So just want to highlight this. So this is really resembling 20 years of research going into this study. This was a rather global study. We conducted it in South America, in several countries in Western Europe, in South Africa, in Russia. And so this was a rather global study, and you see that the survival curve starts separating on day 4, and that we just recently published this in the Lancet Respiratory Medicine. And you saw about a 24% relative reduction here in death on day 28, which kind of remained stable throughout day 60. It's important that we did this on top of standard of care. So these patients, by and large, were treated with corticosteroids, anticoagulants, and 20% also biologics and others like tocilizumab and baricitinib. So, and we saw this effect specifically also on top of these biological and other drugs, which was very, very important. Now, we looked at whether this disease, whether this signal was stable, and here are the different ways of looking at Cox regression. We had originally per protocol defined the second one, which would have been p-value positive, but upon recommendation of the regulatory agencies in the US, we also included site stratification into it and changed it in the statistical analysis plan. This one slightly missed the p-value significance. However, we did a lot of in-depth analysis around this and found that the data were actually quite robust because this upper study here kicked out kind of 61 patients, which were effectively ignored for the analysis. So in every way of looking at all 369 or 361, one was randomized in error patients, this was a positive study. Now, this is just a glance here. These are the European data. We had a pre-specified subset because most of the patients, over the half of them, 209, were enrolled in Europe. And here the data showed pretty much an assembly, what we saw in the very small early study, about 43% relative reduction, which was still present to 31% or 31.6% at day 60. And just last but not least, we also saw interesting trends here, significant trend on renal replacement need, also 1/3 reduced acute renal injury, and others which are not all depicted here. So in essence, we learned from this trial that C5a inhibition, so host response interception, could really lead to a robust survival improvement here. And we, at least with our drug, didn't see any safety concerns And we have in the meanwhile submitted this for emergency use authorization after discussing this with the FDA in the US. Now, this study really confirms a concept that has been researched now for over 20 years, but it's also a proof that intercepting with the immune host response can lead to survival. And you may know that there have been many years of research in the greater sepsis space, which have been frustrating because we could never really get to separate the survival curves in most of these studies. So we feel very much encouraged. The study was also supported by a grant by the Federal Ministry of Education and Research and Science in Germany. And last but not least, I want to conclude. I believe that a targeted inhibition of the innate immune response can actually save lives in viral septic critically ill COVID-19 patients. We here showed some data on C5a inhibition as C5a is target, but there are other targets that have been mentioned already today, such as the Janus kinase 1 and 2, and also the IL-1 receptor and others. So there is a great deal of research going on right now. And I think that the availability of such targeted immunomodulators may be an important element to combat viral sepsis in general and also install a therapeutic pandemic preparedness. I also want to make one last comment here, that I believe that this knowledge that we gained in this type of research in viral sepsis here in COVID-19 may greatly propel and help also developing this in the broader sense in terms of the greater sepsis and ARDS field. And I think that this is one of the great outcomes of this research, which was really unique. And I think none of us has seen that so far, that so many studies around this very important area have been taking place. So with that, I'm at the end. I would like to thank everyone for being patient and listening in. And I hope this prompts more research and more thoughts into how we can effectively use immunomodulators for patients that are unfortunate and end up in this critical ill disease. Thank you.
Thank you, Niels. I hope you can stay with us, and we'll also discuss these topics at the very end. And now it's my great pleasure to invite Markus Friedrich, who was the Chief Medical Officer of the Quality Improvement Campaign, which was launched or mandated by Governor Cuomo in 2013-14 after the unnecessary death from Rory Staunton. And please, Markus, present what you have learned in the context of this campaign.
Thank you, Konrad, and thank you for having me. I want to start with saying this: everybody has the right to survive sepsis. And my colleague, Dr. Sutebo, already mentioned that. You have the right, everybody has the right to survive sepsis. And this was the problem that we had in New York, like in many other areas of the world, that we started looking at the data and we saw variations in mortality, hospital variations from 10 in some hospitals, the mortality from sepsis was 10%. In other hospitals, it was 50%. And talking in plain terms, that means if you walk by accident in one of these hospitals, you have a 1 in 2 chance of dying, versus in other hospitals, you might have a 1 in 10 chance of dying from sepsis. And that was the issue that we started to think about and addressing. In New York, we have had about 50,000 cases of sepsis, severe sepsis and septic shock per year. And we needed something really to address this issue about this in-hospital variation, because what it means is that everybody, we are all physicians, everybody kind of like get educated on the same pathways of treating sepsis and recognizing sepsis. How can it be then that there was a variation in the hospitals? And we saw that not only in raw mortality data, but also in risk-adjusted mortality data. And it was clearly around that time, around 2011, 2012, that it was very clear that using protocols like a protocolized approach to treating sepsis can actually save lives. So does that mean that not everybody is using these protocols? And that was when we came together in New York, and the Conrad already mentioned Governor Cuomo put out a very ambitious goal to reduce the mortality in hospitals from sepsis for 50%, by 50%. And I was fortunate to lead that effort for 6 years. I have since moved on, but I'm proud to present you kind of what we did in New York and also kind of some of the outcomes. Dr. Diaz also mentioned in her 5 points the recognition and also the training of the staff. That was one of the key pillars that we did in New York. And we did this not from the bottom up. We kind of like put in a law that that required hospitals to do like these 3 different things. One is that every hospital needed to submit protocols for the recognition and treatment of sepsis for adult and pediatric. And we had about 200 acute care hospitals in New York. The second is that not only these hospitals that they invent those protocols and the protocol ends up in a down drawer somewhere, but that the whole staff in the hospitals who are clinically have to be trained on these protocols, how to first recognize and how to treat the sepsis patients. And thirdly, that the hospitals have to submit clinical data to the state of New York. We took the data in, we analyzed the data and gave it back to the hospitals. And that is basically what the whole initiative is about. I'm not an expert, I'm a primary care physician. I needed experts who can guide me through, what are the right measures to report from the hospitals to the sepsis. We had a clinical data collection that the hospitals were supposed to send us every quarter their cases. We also then, after we were sure about the data and did a lot of audits on the data, that we publicly reported that data. So right now you can go on the website of the Department of Health in New York and look at every single hospital at the mortality data in their hospital. And we did some quality improvement. So now I want to move over to some of the outcomes that you've seen here. This is like we started, the law was put in place in 2013. We started the data collection in 2014. And so the first data points we started in the beginning, or we got in the beginning of 2015. And if you see that these are average raw mortality cases, we started around 32%. And you see over the quarters of the initiatives, and the initiative is still ongoing, how the mortality dropped by probably a third from the high point out there. And what that means is that at the end, in the beginning of the COVID years, that at least from sepsis, that we were saving about 16,000 lives in total through the reduced mortality from sepsis. Again, the key points are that hospitals were required to use their own protocols, and that the hospital staff needed to be trained on the recognition and the treatment of sepsis. Now you can say, well, maybe this is just a effect only be showing in New York. And there is a great study from a research group from the University of Pittsburgh, who then compares kind of like the sepsis mortality before we put this law in place and after this law in place, and combined and actually looked into other states. The other states were Florida, Maryland, Massachusetts and New Jersey. Massachusetts and New Jersey are the states around New York, to see if this effect of this mandate, of this law that we put in place, actually had an effect in New York, or if it was an overall trend that we were just following with the reduced number of sepsis mortality. And to not my big surprise, but a lot of people's big surprises, was that the law had a pretty dramatic effect actually from before and after of sepsis cases. At the end, the results were that the expected mortality rate in New York was 3.2% lower than what was expected compared to these other states. And therefore, there is some evidence that actually these mandates can work, that there is political aspect. I would not consider this works in every area in the world, but at least it can be part of the toolbox to combat this deadly diseases in all the hospitals. So with that, I want to thank you.
As you did not use up your time, we may have already one question to you before. Yeah, so is there a question to Dr. Friedrich on this this talk? Yes, please. Could you, here's this colleague.
Hi, my name's Hira. I'm from the International Pharmaceutical Students Federation. I also work as an antimicrobials pharmacist in the UK. I guess we've heard from everyone about how serious sepsis is and all the deaths that have been caused by sepsis. I guess my question is, do any of you know what are some of the reasons why we are struggling to manage sepsis? Because we did, in the UK, in the hospital that I work in, we did a quality improvement project on sepsis. It was one that I led a couple of months ago, and we were looking at, in the UK, we have the UK Sepsis Trust. So we have the Sepsis 6 policy. So we have to administer IV antibiotics within an hour of diagnosis, and our audit looked at that, and 80% of our patients were not receiving antibiotics within the hour, and that's in the UK, so where we're very privileged. And so now we're working on how to fix that and what changes we need to make with clinicians. So I guess I'm curious from you guys, do you know what are the reasons why this is not being managed, or and how that, you know, how you would then implement like any changes? Thank you.
Yeah, I think like from our, and when you look at comparable data in New York, there is variation in the hospital, and it has to do with processes around sepsis, maybe identification still. And I think that the UK Sepsis Trust and other areas also in New York, that we started having this discussion about sepsis. So it's not like that this is a brand new concept. And I think that we have to give time for the hospitals to put the right processes in place. You said 8% of the hospitals are not giving the antibiotic at the right time. Okay, 20%. And we see similar, like if I look in our data in New York, we see similar. And the question is now, what is the 20% and how to address this shortcoming there? And there are now quality improvement initiatives from the Department of Health and other areas to address that. Is it, again, is it a process measure? Is that driven by the physicians, or is it driven by the staff that these 20% are not giving that? And I think that is where this work never ends, and it starts or becomes or stays very interesting to see what else can you be done to combat this and bring this level up from 80% maybe to 90%. You will never get 100%, we all know that, but you know, closer to 90% would be probably desirable.
Thank you very much. And I will present now my talk, which in some way summarizes also some experiences. And just to answer also right from the beginning, could you please put up my presentation? Is a question of awareness, because we did a study with 40 hospitals in Germany 5 years ago, and only 30% at the beginning of this study received the antimicrobials within the first hour. Unfortunately, 5 years later, this number was not different despite our efforts. And not surprisingly, the mortality rate was not changed. And that's why, and you have heard that there are differences between countries and outcomes. And I will speak about this issue, which are not related to resources. It's great, and no doubt that countries who have no access and have very poor healthcare systems, but also there are differences between countries who have similar resources, and I will talk about this. And this already alludes to the fact, and I mentioned Rudolf Virchow here, who understood already more than over 200 years ago that there's an obligation by the physicians to point out the problem, but we must get the involvement of the policymakers on a global scale, on a national scale. And that's why I was so glad to see that on Friday night, the first Global Health Prize with the name of Rudolf Virchow was awarded for the first time to make, because this will help. And how important the healthcare systems are was clearly demonstrated with the start, and this is data from the US, that between 1900 or around 1900, the policy over there in US had already 40 states with health departments. And then were other hygiene measures as chlorinication of water, sanitations. And you see this decline, which interestingly was only in the crude mortality rate from infectious diseases, which was only interrupted by the so-called influenza pandemics, the so-called Spanish flu. And you see that there was a further decline continuously, of course, also by great research, by development of vaccines, by development of antimicrobials, et cetera, and this led to the wrong notion, unfortunately, that the book of infectious diseases could be closed. And this was a misconception and led to the fact that infectious diseases after World War II were dramatically neglected in comparison to other disciplines. And how important you see, and we have discussed this before, there are these huge differences on a global scale, but also in the US, in Sweden, and in Germany, you have a sepsis incidence, which is not so much difference. Of course, there are countries in sub-Saharan Africa where it's 10 times higher, but still we have an issue with sepsis also, also in high-income countries. And Sir William Osers has pointed out around 1900 that humanity has 3 enemies, and by far fever, which is nothing else than what we talked about today. And this is still true if you look at the data nowadays. We still, more people die from infectious diseases and sepsis than from war and hunger and even cancer. And AMR, we have discussed this, of course, adds to this problem, but we lose much more patients from sepsis because they don't get an antimicrobial in due time, which we still have to a large degree than from really antimicrobial resistance. So that's why it was so important that we came up with this WHO sepsis resolution, which urges indeed member states to strengthen and to take measures on a national scale to implement sepsis in their national health programs. And it was great that on this occasion, also the WHO spoke out, and Dr. Tedros called it a tragedy that most of sepsis cases are preventable. And what he said in the opening session in German, that good health is ein Menschenrecht. He said it in German. And this is another reminder that policymakers need to take care not only on infectious diseases during time of pandemics, but also realize that annually 10 million die from sepsis or even more, because half of sepsis patients are not documented so far in the ICD, etc., etc. So they must take up this silent pandemic also. And that's why it was very important that the German Minister of Health, Karl Lauterbach, made it happen that sepsis for the first time was mentioned not only in the joint declaration of the G7 ministers of health, and they pointed also out that they wanted to ensure that the synergy between antimicrobial resistance, antimicrobial stewardship, and IPC programs through national campaigns. And also they will help, this is at least set out in this declaration, to really that every member states of the WHO will make this happen. And just to point out that the quality of a healthcare system and the implementation of quality measures which have worked very well in aviation, etc., simply may result in a halving of the sepsis deaths as depicted on this picture from a publication on the trend of the mortality rate from ICU-treated sepsis, which halved in Australia from 35% to below in the range of 18%, just by implementing and make it mandatory to have so-called rapid response systems. Because most countries until now, including Germany and others, have an alarm only at cardiac arrest or shortly before cardiac arrest. So in some mostly Anglo-Saxonian countries, in the meanwhile also in other countries, they have recognized you have to educate every healthcare workers to understand where there is a deteriorated patients, etc., etc. So, and this makes a difference. They didn't talk about sepsis at all. This happened without a sepsis campaign. And this went along, of course, also in an overall a decrease in mortality rate in these hospitals. And they did also have quality improvement in place, and it's mandatory for every hospital, what is called critical incidence reporting systems. And they learned that still in Australia, they also had problems with sepsis-related issues, and they could decrease by campaigns the mortality rate. This was the case also in Ireland, where a national campaign resulted also in a dramatic decrease in mortality rate. And this is data from the UK Sepsis Trust, where they indeed achieved what you reported. They were able, by increasing awareness over 2 years, to increase the number of patients who got their antimicrobial in the first hour from 30% to 80%. And this resulted, and this is the dotted line, in a decrease in mortality rate. So it's true, we can do it, but it needs nationwide effort. And it was, now he just became, as you know, financial minister, Jeremy Hunt, who cared, who spoke out, and who criticized unnecessary deaths when they occurred. And they have education on bus stops, etc., and not there. Every family gets a book which educates who gets a child, and there's a 24/7 number that they can ask for. So they acted. Unfortunately, I have to report that we failed in Germany with a voluntary approach which involved 70 hospitals. And you see, between 2014 and 2018, nothing happened in terms of a change in mortality rate. And there is poor education, and this is a poll we did with a renowned agency, Allensbach, here, and we found still 2/3 of Germans think sepsis is just an issue of wound infections. Only 10% understood that COVID-19 and influenza also may result in sepsis. And look at our vaccination rates against influenza and pneumococca. It's half of that in other countries. And this may explain that our mortality rate, according to a recent study where we also looked in the health records, is almost twice as high as in Australia and higher than in other studies. So we are glad now that also our Ministry of Health understood we need to do something. We are doing a campaign, and which is supported by our German Ministry of Health for 4 years with 4.5 million per year, 1.5 million per year, and that Germany recognizes sepsis. And I would encourage then that really we all jointly put pressure both on the institutional level, on the national level, and to make and to speak out and to use the word sepsis, which unfortunately I have not heard in the opening session of this conference. But we will not give up. We will remind what Virchow also already realized 200 years ago. Thank you very much for your attention. So we got now another 15 minutes and to discuss and to ask questions. Please, both those who have joined us online, but those of you who are in the room, ask your questions. And yes, please.
Hi, thanks very much for the talks. Jakob Simmang from German's Weekly Die Zeit. I was wondering about public education. I think it was stressed about the effectiveness of public education. Is there any research basically on what is necessary to, what the message should be for public education? And then relating to that, for Professor Reinhardt, a question, will the program you just talked about, will that be evaluated in terms of effectiveness? I would be interested in that. Thanks.
Yeah, I think so. If you look on the fact that the incidence of HIV and the death rates of HIV decreased dramatically, globally we have about 650,000 deaths from HIV, and the incidence of HIV in Germany is around 3 of 100,000. And this is due to the fact which included also public education. So it's great that at every bus stop in Germany, since 10 to 15 years, the issue of sexual transmitted infections is addressed by a special grant, which is decided by the Bundestag of around 10 to 11 millions. The grant for overall infection prevention for infectious diseases or vaccination was 650,000 in comparison to this. So what I am saying, so we need similar efforts also to educate the public, and we need mandatory measures for any hospital which have been demonstrated to be effective in so many countries. So, and yes, we have one project for Berlin and Brandenburg, where we evaluate, and there are some colleagues in the room who work with us as Sepsis Foundation on this project, where we educate both the public, where we speak to physicians, and where we do before and after access both. How developed this is, the RKI is involved to check what is the impact on vaccination rates, what is the impact of the knowledge on sepsis by physicians, by nurses, etc., etc. So there is, yes, this needs to be accompanied, but I think we have so many examples that education works. There was, yes, please.
Brigitte Böhlen, WUI Foundation of Family Carers. My question is very simple. Who shall be educated? The medical system, the healthcare workers, the professionals, or society, the people? And how can I, as a normal person on the street, how can I get more knowledge, and how can I get connected with you, the experts? And what do you want me to do?
Yeah. So I think this again is a very excellent questions. And if we want to make a really progress, everybody, we asked in 2012 when we launched the World Sepsis Declaration that sepsis becomes a household word. like it is. We were even to educate people what is HIV. Everybody knows now what cancer is, but nobody knows that sepsis infections kills by an overdrive of the immune system. And as long this is not clear, and this needs to be known, first of all, by policymakers, by health authorities, and by WHO. I wanted to ask Jeanette, how come, you have explained that key people in the very beginning of this pandemic did not use the word sepsis in the context of COVID-19, or did not speak up in this, what is clearly that he speak up about AMR, AIDS, etc., etc. So so that there are a lot of questions, but so that's my take on this. Yeah.
Oh, I think
Yes.
is it working? No, sepsis happens, or, when we were in the most recent discussions from some of the other sessions, it was so important to stress the community's role in recognition of infectious diseases. And we focused a lot on the emerging infectious diseases, that the first warning is in a community. It's the people, right? It's not it. And I think this sepsis, like other threats, I think it has to start with the community and the people, from youth, from children, through families. And that's why I think some of these interventions have been described, like in the UK, where these booklets, and I think that's where we need to start. We also need to work on our healthcare workers, on education in the health system, pre-medical school, pre-education, and then setting up the systems and the processes within the health system and in the community, so that if there is a trigger, a warning that someone has sepsis, just like, to call if you're having chest pain, you think you have a heart attack, that you also are concerned if you have an infection and you have a symptom that's making you suspect you have sepsis, then you also call for, get some help. So I think that's the paradigm that we need to shift, and a lot of more work needs to be done on messaging that way, especially in different communities, right? And I don't know if Emmanuel wanted to comment. Even right now for Ebola, let's just talk about one infectious disease that's happening in Uganda. The importance of honest communication, community engagement, understanding the risks on how you can get Ebola, and how you can prevent yourself. All this without causing any stigma is really important. And I think we have to take those similar approaches in sepsis. Thanks.
As we have left only 10 minutes, may I ask perhaps each panelist to answer this question? What is the problem that we are not on equal footing with other comparable health threats? And Moshen, you want, and then we have still some, we will answer more question from the audience.
Thank you. This question has two answers. One answer is for the high-income country. Yes, that's method that UK did. That method that we teach people, we teach health worker and doctor, it's work. But for the low-income country, the biggest problem is that we have to help them, or they have to make their health system. The problem is that in the low-income country, usually there is no health system. And people die with sepsis without any understanding what was the sepsis, what was the causes of that. We put many pressure on the communication, on the people, on the doctor. Okay, when there is no system, when you have a very, very big number of the infectious, very big number, when you go to the hospital, you die in the hospital due to the situation in the hospital, due to the hygiene in the hospital, due to the, there is no any instrument in the hospital, then how we can say that people have to help? No, government have to help. Government have to make a hospital, have to make a health system, have to put money for the people. Then yes, in this river, we can do everything that we want, but there is no river in the low income country. Then my point is that biggest problem is making health system, making something that we can treat sepsis on that. Thank you.
Thank you. So Manuel, you want to comment, and then perhaps Niels, and then Marcus. So, yeah.
Thank you. The really all important points that have been raised, and what I would like to emphasize, because I used to work in the UK as actually a advisor for the National Health Service in the UK for sepsis before I moved to Abu Dhabi, is these improvements which have been described in the UK and Australia have not happened by chance. They happened because there was a systematic plan. It happened because the Department of Health in the UK worked with the UK Sepsis Trust and other stakeholders to put in a plan for sepsis improvement. Same for Australia. And that's exactly the point that I'm making, that these improvements will not happen just because we just want them to happen. It has to be led at national level, and it has to be part of a strategy to improve every aspect of care, the education within members of the public, and using also social scientists to figure out what the message is for that context. What is the message for the UK is not the same message for Uganda. And again, making sure the population understand what sepsis is and what is the key message we're asking them to do with respect to sepsis. Similarly, education amongst healthcare workers, having a strategy for performance improvement, quality improvement in the health service. We heard about what happened in New York, in the UK. We need similar programs at country level across the board, especially in Africa, where my focus is, and etc. and research and etc. So these are what we need to consolidate all these in action plans, and what we need is governments to step up, and the different stakeholders, CDC, Africa, African Union, all that, WHO, Afro, to step up and work with GSA and African Sepsis Line to help develop these action plans that can then lead to the improvements in outcomes that we've seen in other parts of the world, like in the UK, Australia, New York, etc. Thank you.
Thank you. Niels?
Yes, thank you. So, you know, Emmanuel made some very important points on what needs to be done systemically to help. And your question was also, you know, what we believe the key problems are, why sepsis is not recognized. And I can only speak for the healthcare systems I worked in, a bit in the US and mostly in Germany. And I think one problem may be that sepsis doesn't have like an ownership as of a disease, like, you know, so sepsis concerns every doctor. So we need, and everyone should know about it. So we need a broader push, as Emmanuel just rightfully so mentioned. And the other thing is, sepsis oftentimes happens and kills in a very sterile environment on an ICU. It's where it ends most of the time in our Western European system and Western world system. So it's not something that the families are very close to, that is taking, so there's a lack of empathy. So we need to encourage patient initiatives much more to speak up and to say and to ask for what Emmanuel just mentioned. I think it's always good if we do it as physicians or if company do it, but the patient initiatives that have also stories to tell could be a very important key, and we need to get stronger there. Thank you.
Thank you, Niels. And as there are only 1.5 minutes left, or 1 minute left, Marcus was so kind to hand over to me for some final remarks and summaries. As I mentioned from the very beginning, we have, without any doubt, made big progress. Having a WS sepsis resolution, having it on the level of G7, we work strongly to get it on the level also of G20, but also bodies like UNICEF, bodies like the United Nations, and other, like the Bill Gates Foundation. Bill Gates has announced, and it was great in the opening, they will spend another $1 billion or more to end polio. We need, and it's doable. And the same is true in some way for sepsis. And we need that all stakeholders, including the public, including the policymakers, including industry, going together. AIDS is a good example. Cancer has made progress, and they have started in 1950 asking Mr. Nixon and have big aids for the Manhattan Project against cancer. They asked for a moonshot against cancer, and they understood they need to campaign. And so that's a combination, but we cannot wait any longer, because a quality improvement program which was set out and started for sepsis in Germany 4.5 years ago will take another 3 years after it becomes mandatory for every hospital. So that's not the way how to solve such problems. So every country has to, but we have to learn from each other. And I think this is great. We have data now, which we did not have 10 years ago. We have increased understanding also to some degree on the policy levels. And we need to have national infection management programs, which include pandemic preparedness, AMR, sepsis, infection prevention, etc. And we must come out of the silos and understand, because otherwise we won't not create the lobby that we need to make a difference. Thank you so much for contributing. Tell about sepsis, speak about sepsis, and help us also in the future to make this happen. We as GSA and also as German Foundation and the UK Sepsis Trust, etc. This has made the difference. And we shall continue to follow this path. Thank you so much for joining.